it's a real an absolute real pleasure for me to all join you, and thank you so much for the kind invitation to speak. And of course, it was World Osteoporosis Day, wasn't it, on Sunday? So that was a bit special. And, you know, I admire everything that you do and more, all of you as a society and as chartered physiotherapists. And obviously at Surrey, we train dietitians and nutritionists and food scientists and sport and exercise scientists. So we, and exercise physiologists. So we obviously, you know, have a close collaboration in terms of allied health professionals. So what I'm going to do is, first of all, let me share my screen. We've practiced it once, so I'm hoping that it's going to behave for us. And that, let me just take that to the top, and I'm hoping that you can just see my first slide. And I'm hoping that it's gonna, let's just put it on. So I'm hoping that you can all see that.
Yes, yeah, we
Lovely.
can.
And you can all still hear me. So that's a good start. You can hear the speaker and you can see the slides. This is always the bit in a lecture when my students think, goodness me, she's trying to give us a lecture, she can't even get the slides moving. So I'm very grateful for technology. So what I'm going to do, and obviously I'm so happy for you to have all the slides. I've sent them through. I've got a few updates on these, so I will send through the PDF. But if you'd like the original PowerPoint, then I'll find a way of transferring it over to you, because if the file's so large, I got to send it as PDF. But you are so welcome, you know, to all of the slides, and I hope that this presentation will be a real help to you in the wonderful work that you do. And what I've said is, perhaps I can pause at regular intervals just to take any questions that you may have, or I can keep going. We can maybe see how as we go. And I know that I've got one, so I've got till 8:30, so it's now 9:30, 7:37. So I will make sure that I don't run over 8:30. I think when I sent through the slides, I think you probably all thought, gosh, she's going to be here till midnight with that many slides. But I really want it to be a session that you come away from and really think, gosh, I really learned something there. And if that is the case, then my job is done. But obviously can have all the slides and it's got all the references on there. So what I want to do is to really take you through the key aspects that we have around nutrition and bone, particularly nutrition and osteoporosis, but I can maybe touch on particularly osteomalacia. And I'm going to start with calcium and vitamin D, because those two are really the most important nutrients. And those would be the two that I would say in your practices when you're speaking to your patients, to your clients. Those two are the nutrients that we know most about with respect to nutrition and bone, but there are others, and I'd like to just share with you, even if I do it only very quickly, around acid base and vitamin K, because they have been very topical. And with an acid base balance, I'm talking about potassium and protein, and then really bring you up to speed with everything that we know. And I might skip a few slides and I will just keep an eye on the time. So of course, let's put it into context. And I know in an audience such as this, I don't need to spend very long defining what osteoporosis is, but of course, that's what it looks like under the microphone. I was there in the audience in 1990 when that WHO definition was made at the First World Congress on Osteoporosis in Copenhagen. I was there as a PhD student listening to all the discussions. And of course, that definition of osteoporosis has stayed the test of time since that consensus development conference paper that came after the meeting in Copenhagen. And of course, it is characterized both by low bone mass, but also microarchitectural deterioration of bony tissue, with, of course, fracture being our end point. And that doesn't have to be necessarily osteoporotic fracture. It can also be stress fractures, and people often don't really think about that. But of course, stress fractures and the female athletic triad, as it was known, and that's now been redefined by the IOC to REDS, relative energy deficit syndrome, is a big issue, and is certainly something I think everything I talk about refers also to stress fractures as much as it does to osteoporotic fractures. And avoiding being calcium deficient and avoiding being vitamin D deficient is extremely important. So blown up, what does that look like under the microscope? Of course, this is what it looks like. These slides have been very kindly lent to me by Professor Tim Arnett, who I've had the great pleasure to work on with regard to acid base and bone. He's based in UCL, but he's done so much work as a bone biologist. If you blow that up again, you can see it, that it really is disconnectivity. And then, of course, this is the culprit, the osteoclast. What we're trying to do is slow down in older age how much activity there is from this bone cell, the osteoclast, the bone resorbing cell. And of course, that is where most of our treatment strategies now, the bisphosphonate drugs, are targeted at osteoclastic activity. But there's so much that can be done through a dietary approach. I would say, of course, I wish I could stand here and say, if you follow this diet, you won't get osteoporosis. It's not that simple. And of course, treatment strategies are very effective, but there is definitely a place both for diet and for physical activity. I don't touch on physical activity very much in this talk, but of course, bone accommodates the forces applied to it by altering its amount and distribution of mass. That is Wolff's law. Bone mass accommodates the forces applied to it. So, of course, what it means is that exercise is there, and of course, bone will develop and grow in density. And so what we should be thinking between the best diet that we can give to our patient and the best type of physical activity. And perhaps we can come back to that in the questions. But of course, as you'll see here, this is the process of bone turnover. And what we're trying to do is to make sure that that is in balance. And of course, it becomes very much out of balance. These are all the different markers, but it comes out of balance as people get older, but particularly for women during that menopausal time. We know that 1 to 2% of bone can be lost over a 5 to 10 year time span. So for some women, they can lose 20% of their bone density during that menopausal time. So we must pay particular attention to lifestyle, which of course is diet and physical activity, but it's also very important when we're trying to build as much bone in the bank as what we can. With puberty, you'll see that on the slide, that of course about 60 to 70% of bone is laid down during puberty, and boys are of course around, the average age is about 14 years for puberty. For girls it's about 12 years. And so what we don't yet have anywhere near enough data is to say what is the optimum timing for calcium supplementation or increased calcium intake or vitamin D status. What we know is to be vitamin D deficient. So that is defined by a vitamin D level, your vitamin D status, which is of course 25 hydroxy vitamin D. If that is less than 25 nanomoles per litre, and if your calcium intake is below the LRNI, the lower reference nutrient intake, which in this country, of course, is set at 400 milligrams per day, you will have inadequate bone mineral accretion. And so this side of the graph, if you like, is so important to building bone in our younger individuals and helping to ward off stress fractures. But it's also very important to try and offset age-related bone loss, which happens as part of the natural aging process, and is something that, again, I think we have so much more research that we need to really understand what is the optimum timing, and what are the categories that fit within that. And then what we see, of course, and I'm not going to spend long on this slide either, but it's a huge public health issue and it's not going to go away. And we've got to really think about prevention, what we can do to prevent as much as we can to develop. So we need to develop bone and make sure that it's maintained at a high level. Now, when we think about it, I always put this slide up because the first nutrient that we'll always think about would be calcium. Of course, 99% of total body calcium is contained within the bones and teeth. If your patient comes in and says, I think I'm calcium deficient, of course, yes, you can measure serum calcium, but it won't tell you about bodily stores because it's homeostatically controlled. So that makes setting calcium requirements very challenging because, of course, parathyroid hormone, as well as the active hormone of vitamin D, 125, as well as calcitonin, those are your three calcitropic hormones, and they are so important to maintaining that blood calcium level. And so what we've got to avoid is, of course, for individuals not to be certainly vitamin D deficient, because you can see here that vitamin D, 125 dihydroxyvitamin D, the active hormone of vitamin D, is critical for calcium absorption. So if you are vitamin D deficient, then you're likely to have issues with calcium absorption. And of course, if you have low vitamin D status, you will see an increase in parathyroid hormone. And if we've got too higher PTH levels, that will, as you can see here, will stimulate calcium to be released from bones. So bone resorption will be higher. So these, of course, are the levels that are set by our different bodies. So this is the Institute of Medicine, the USA, and this is, of course, the UK reference nutrient intake, the RNI. And as you can see, for adults, it's 700 milligrams per day. It's much higher in America. But of course, what's important is that the remit of RNIs is about avoiding deficiency, whereas the US panel, the Institute of Medicine panel, is about optimizing health. And that's why you see a difference. What is key, of course, is knowing, is making sure that individuals are not below the LRNI for calcium, below 400 milligrams per day. And when we think about this, we think about the Eat Well guide, and often we put it up and people kind of think, oh, I've seen that in GP surgeries, and they don't really focus down on what it is telling you. So I think this is always such a useful tool, because so much time has gone into really thinking about what does it look like. And of course, it's to have a really good portion of fruits and vegetables in the diet, minimum 5 a day. The data that I'm going to show you with regard to fruit and vegetable and bone is probably the best diet for bone health that has been done, has been shown through a whole food approach, has been the DASH diet, dietary approaches to stopping hypertension. And of course, that was about 9.2 servings of fruits and vegetables per day. What's also very key, of course, is your good quality protein. And I will share with you our 2 very large meta-analyses that we have done on protein and bone. So good quality protein mixed together with plenty of fruits and vegetables. And obviously the fruit and vegetable component points to the acid-base balance of the diet. But what one must also have are plenty of dairy products or non-dairy alternatives. And that is so key. And I think there's been so much that has been damning about calcium per se, but also dairy products. And it's misjudged and it's misplaced because it doesn't base itself on what the evidence shows. and I will just touch on that as I go through. And I thought I would just share this with you because it was quite amusing many years ago now. The Royal Osteoporosis Society, I've been one of their scientific advisors on nutrition for, oh gosh, it's probably about 30 years now. And they're such a wonderful organization. And I would point you to all their website and all the information that they have. And they asked me to do many years ago a media day for them. And I said, absolutely. I scrawled it in my diary. So I was there for them all day. And I thought it was just going to be local media. And when the media invite came in, I looked down and took my breath away that I had 3 minutes on the Today Radio 4 Today program. And so I shall not forget, I think I was on at about 6:54. So I was on the 04:24 or whatever it was from Guildford. I didn't know British Rail started that early. And I shall not forget, I was sitting in the waiting room thinking, okay, I've got a bit of time to, I've got 3 minutes at best to ruffle feathers, because what has been said a lot on social media is about clean eating, about completely cutting out dairy, with no mention of the fact that 60% of our calcium comes from dairy products. So if you choose to exclude them, then you are going to be certainly probably below that LRNI, below that 400 milligrams per day, unless you pay particular attention to other non-dairy forms of calcium. And so I shall not forget my saying to Sarah Montague, who of course now does The World at One, health social media gurus really don't know what they're talking about. And I think she looked at me as if to say, goodness me, that was quite a big statement to make. And so I came out of that studio, and the Jeremy Vine producer had heard what I'd said and said, could you come on and debate what you've just said live with some health social media gurus? And I said, absolutely, sir, bring them all in, fit as many as you can in Mr. Vine's studio, and we can have a really good debate about this. And I shall not forget it. I think it was on at 12:22 on his program, and not a single health social media guru would come in and debate with me. And I remember saying, well, Mr. Vine, I think that says it all, that actually what we've got to do is to give a balanced argument and not exclude one group without paying particular attention. We say, a bit like the 5 a day, this isn't a government recommendation, but it is certainly, I think, very useful. 3 portions of dairy will get you to 700 milligrams per day. So that's a glass, 200 glass of milk, a matchbox slice size of cheddar cheese, and a yogurt. But you can absolutely achieve your 700 milligrams and indeed more by not having dairy, but paying particular attention to all your plant-based milks. Are now, most of them are fortified with calcium. All white flour in the United Kingdom is fortified with calcium. So it is very possible. And if you have a look on the Royal Osteoporosis Society websites, it's got all our very helpful booklets on how you can achieve that 700 milligrams per day. And of course, what we made sure to do was to get that message out there, and really thinking about that dairy-free diets, that if you don't replace it, then you will not be, without paying particular attention. And it's one of balance, I think. It's always one of balance. When you look at calcium, there is quite a lot of controversy. Some would say that calcium reduces fracture. Some would say it increases fracture. And I think that is, or not necessarily increases fracture, but certainly doesn't prevent it. And I think that debate will run and run. I think when you look at the evidence that is there, if somebody is eating enough calcium in their diet, it's unlikely that they are going to need a calcium supplement. But if they are below that LRNI for calcium, then they will be at risk of poor bone health. There has also been quite a lot of controversy in the media about the cardiovascular complications of calcium supplements. You may have seen that. That may be something that your patients ask, because it's received a lot of attention. Where it came from was analysis by the New Zealand group on studies where they had looked at calcium supplementation, and that they found that calcium supplement users seemed to be at a greater risk of ischemic heart disease or markers of heart health. Those studies were not powered. Those were bone studies that they did. They were fracture at the end point. So they were doing secondary analysis. And we always have to be careful when we do secondary analysis. If you look at the evidence, this is the best study to date because it's the largest one. It's based on the UK Biobank. And what they have shown is that calcium and vitamin D supplementation are not associated with the risk of incident ischemic cardiac events or indeed death. And there have been other trials that have since been published since that New Zealand work to show exactly the same, that there isn't an increase in those studies and those prospective cohort studies. Nonetheless, I would say if your patient is achieving enough calcium in their diet, they probably don't need to take a calcium supplement, except, of course, if they have been prescribed bisphosphonates, because all bisphosphonates are prescribed with calcium and vitamin D, because that's how the trials were undertaken, and that is how they are recommended by or approved by the MHRA. And we can maybe come back to that in the questions. I think what's wonderful now is to see it. This is the Royal College of Physician guidelines. I had the great privilege of doing my PhD with Professor David Rood from Aberdeen, who was responsible for writing the Royal College of Physician guidelines. And what's so great is to see how many times diet and exercise would appear in those Royal College of Physician guidelines in a way that they didn't, 30, 40 years ago, which is wonderful to see. And then in the updated guide, it talks about calcium, it talks about vitamin D, and there's a little bit on protein, but we've still got so much work to be done in the field of nutrition and bone to really answer it from a fracture prevention point of view. Now, when we think about vitamin D, I can't possibly mention vitamin D without mentioning this wonderful inspirational scientist, Dame Harriet Chick. She was once the president of the Nutrition Society. She was one of the first scientists to ever do a study looking at vitamin D and the prevention of rickets. This is the actual study published in the Lancet in 1922, and you'll see here these are her results. And what she showed was that during the winter, children who were given cod liver oil, you completely eradicated the amount of rickets that were occurring. But in those children who didn't get the cod liver oil, half of them developed rickets. And she did all the sunlight exposure work as well. And so if you look at the history of vitamin D, and of course it was 100 years old a couple of years ago, so I can always send through, we've done a couple of editorials about vitamin D and really sets the history, and you can see how much British scientists have played such an important role in vitamin D and us understanding its metabolism. I think it's a misnomer. We should never have called vitamin D vitamin D, a vitamin, because all vitamins are vital amines. Amine is, of course, a chemically composed group. Vitamin D is actually, it's not an amine group. It's not made up in that way. It's a prohormone where your main source is actually sunlight exposure. And it's the only nutrient where your main source is not one of diet. It is actually UV exposure. And how that works is, as you can see on the slide here, so we've got 7-dehydrocholesterol that sits just under the skin. You need UV rays to hit onto the skin to start to make vitamin D. Then that is hydroxylated in the liver to give us 25 OHD, 25 hydroxy vitamin D is our best clinical marker for status. And it then goes on to further conversion in the kidney to give us 125 dihydroxyvitamin D, which is the active hormone of vitamin D. But that wavelength has to be between 290 and 315 nanometers. This is the same slide blown up, but you can see 25 hydroxylase here, these, and then 1 alpha hydroxylase. These enzymes are so important to doing those conversions. What's very clever, and I don't show it in this slide, but our body is very clever. You can never become vitamin D toxic through UVB exposure, because what will happen is once you've reached that threshold, which would be after about 20 to 30 minutes per day, it then goes to tachystrial, and that is metabolically inert, and you won't make any more vitamin D for the day. Whereas with diet, or certainly not diet, but certainly with supplements, we have to be very careful, because you can become vitamin D toxic. And what we also know is that what we now realize, of course, as scientists, is that you will only make vitamin D between April and September. So the British winter is a huge challenge for vitamin D health. And we know that vitamin D is so important to all these other activities, all these other health outcomes. Particularly, these are, of course, children with rickets. The adult form of rickets is osteomalacia. There are so millions of people who have, during the winter, mild osteomalacia that is not enough to be picked up on a radiograph, but presents itself with muscle ache, bone ache, lethargy, susceptibility to infection, tiredness, and it is because they are mildly osteomalacic, i.e. they simply don't have enough vitamin D. And that is, I think, really well established now, that you can have mild osteomalacia and have all of those factors, and for it not to show up on a radiograph. The WHO estimate that 2 billion people in low to middle income countries are vitamin D deficient, and NICE have estimated that per year we spend £100 million on vitamin D supplements, and we've got to, over time, get more fortification of vitamin D. The best way of telling whether you're in the right sunlight or not is that your shadow has to be shorter than your height. So next time it's a sunny day, have a look at your shadow and it will be double your height at the moment, and that won't change until we get back to April. So now when we look at that and we just think about that, and I'll come back to those couple of things in just a minute. Of course, many countries have now reset their vitamin D recommendations. I have the great honour of sitting on SACN, the Scientific Advisory Committee on Nutrition. I was part of the working group that devised the new RNI for vitamin D, which was 0, but is now 10 micrograms per day. That represents a huge challenge for the United Kingdom, because you will achieve no more than 140 international units, or 3.5 micrograms per day. So, of course, 1 microgram equals 40 international units. So the recommendation from government, and of course that's our job on SACN, is to do the risk assessment. We're not allowed to do risk management. That is that's not within SACN's remit. But the government's recommendation is to take a vitamin D supplement of 10 micrograms during those winter months. And for many people who don't get out in sunlight during April to September, that they should take it all year round. That modelling work that we did, that was based on a lot of the work that Professor Kevin Cashman and Professor Mairead Kiley from the University College Cork have done all that modelling work, that taking 10 micrograms will prevent you from being below 25 nanomoles per litre for your deficiency. And of course, if we just think about that, where are you putting that? And of course, the Institute of Medicine go higher than that. Why? Because they're talking about optimization of health, as does EFSA, the European Food Safety Authority. If you type in EFSA vitamin D upper limits, in addition to sitting on SAC, and I've spent the last couple of years also sitting on EFSA, and last summer we published the new recommendation, or not the renew, it stayed the same, but all the work that we did to review the tolerable upper limit of vitamin D, and that stays unchanged at 4,000 international units per day. And that has been endorsed, or would be, is the same as SACN and IOM. So what that means is that you can take 10 times the RNI safely, but don't go above 4,000 international units per day. I would question somebody who is on that higher level. If you look at so many of the trials, it is the low dose daily amounts of vitamin D that have shown to be effective, and not the large bolus doses. And perhaps again, we can come back to that in the questions. Now, I'm going to just flick over these just to say this was one of the trials that was funded by the government to really set, it was with ourselves at Surrey and with Manchester, looking at the effect of diet and sunlight exposure. And what we show, of course, is that women, these would in women, I think we'd see exactly the same in men, that they drop during the winter. Our South Asian women were deficient for the entirety of the year. And we've now done a lot of work on the UK Biobank, and what we show, so we've got huge numbers of, you can see them here, huge numbers of ethnic and minority groups. And what we can see, the extent of the vitamin D deficiency is almost universal in UK South Asians, with 92% below 50 nanomoles per litre, 55% below 25, bearing in mind that 10% were below the detection limit. What we're now doing as a SACN panel, and if you go on to SACN SACN, all the minutes of all our meetings are there, all the reports are up there for free. What we're now doing is reviewing the RNI for ethnic groups to see if that 10 micrograms is actually enough and whether it should be higher. So that work is about to start. You will also see the report that we've done on vitamin D fortification. The Secretary of State asked us to do that. So we've now done a report to government, because in essence, if you look at what Finland have done, they have led the world with regard to preventing vitamin D deficiency, because so many of their foods are fortified with vitamin D, and they've done that safely with no episodes of vitamin D toxicity. So let's watch this space. Now I'm going to just slip over these slides, because otherwise I'm going to run out of time. But just to say, you have your D3 source, which is the animal source of vitamin D. You have your D2 source, which is your non-animal. Mushrooms are a good example of D2. If I've got any mushroom lovers in the audience, April to September, put them on the windowsill when it's a sunny day, and you will increase the vitamin D2 content of them, because it's the ergostrol that's in the mushrooms. So don't go and buy the expensive UV irradiated mushrooms. You could do it yourself. What we've now just got is a new 5-year government grant with Professor Kathy Martin from the John Innes Centre, together with the Quadram Institute, to now look at tomatoes, and whether they've, Professor Kathy Martin has done some wonderful work gene editing tomatoes. So we're now doing a big trial to see if we can increase the vitamin D content in plant sources of vitamin D in plants. And that work is underway and will take us a couple more years to do. But certainly D3, there is a difference. And again, I'm going to skip over that, but this was another big grant that we got from the government. And if it had been said that it didn't matter whether you give D2 or D3, you see the same change in vitamin D, that is not true. D3 is so much better than D2 at raising and maintaining vitamin D levels, but nonetheless, the D2 does still work. What I would also say is, of course, there have been a lot of studies recently that have been published that don't show a benefit of vitamin D in preventing fracture. My reply to that would be as follows. Many of the trials, in fact, I think almost all of them, the baseline measurements of vitamin D show that the subjects going into those trials were vitamin D replete. They already had enough vitamin D. They were above the threshold even of deficiency. I think most of them, I think the average in this study was about 60 nanomoles per litre. So giving somebody more when they've already got enough doesn't necessarily mean that it will have a beneficial effect. And I think it's very important, for us to bear that in mind. Now, I'm going to just stop there and just see if there are any questions, and then I can just carry on and just say a few things about vitamin K and acid-base homeostasis and protein in the remaining time. But maybe I should switch to the chat and just see if there's anything in there, or if there's anybody who would like to ask a question on those aspects that I've raised around calcium and vitamin D. And I hope that's been helpful. I've tried to give you, the up-to-date thinking of where we are with both those nutrients.
Thank you, Susan. We do have one question in the chat, which is from Joe, and says, any advice for vegetarians and vegans about vitamin 2 supplementation, as D2 doesn't raise levels as well as D3? Do they need to take a higher dose October to March?
Well, that's a great question. I would say there is so the work that we're now doing with Kathy Martin. So if you type in Professor Kathy Martin, I'm sorry, I did have a slide of it, and it seems to have dropped off. If you just type in Professor Kathy Martin tomato plant vitamin D, it will come up with her Nature Foods paper that came out a couple of years ago. So watch this space. We are now we've got a big grant from the government to look to see if that tomato is bioavailable. So that trial probably should be finished. We're running it, or just about to start it, and it will be finished by next year. So that is a D3 source, a vegan D3 source of vitamin D. So that might be useful to you downstream. But right this moment in time, the only D3 vegan source is lichen. I have asked but not been able to get from the manufacturers evidence to show that it's really bioavailable. So without that evidence, I would say vegetarians are okay to take D3 because it's extracted from lanolin. So vitamin D3 supplements are extracted from lanolin when the sheep is just sheared, so it doesn't have to be sacrificed. So it is vegetarian friendly, but of course not vegan friendly. So yes, take your D2 supplement, but just take slightly more.
Brilliant, thank you. We've got a couple of questions about sun exposure. So what about the balance between wearing SPF for skin protection and getting enough UV rays? And how do we balance sun exposure advice with the advice to get UVB exposure daily in the summer? How much skin needs to be exposed to get an effective exposure of UVB?
Oh, that's a great question, and a very difficult one to answer. But if you have a look in the second report, so Professor Anne Webb from the University of Manchester wrote the chapter and on UV exposure. She is a photobiologist expert. And what we know is that the minute you put on sun cream, or indeed face moisturizer, you will block out vitamin D because it's UV, protective, as is indeed clothing. So what you need to do is to have some time where the skin is exposed to sun, but safely, not in any way allowing it to burn. what we say, or what dermatologists say, is about 10% of your body is your face, your neck, the backs of your hands. If you can expose more, the more body surface area that you expose, the greater your vitamin D levels will go up to a certain extent. But if you look at the data, depending on the skin color, how dark the skin is, you will need probably about 20 minutes if you have a light skin, about 30 minutes if you have a dark skin. And if you can expose your face, your neck, the backs of your hands, even your arms for about 20 minutes or so, that will give you your vitamin D supply for the day. Do not in any way allowing your skin to burn, because then of course you will increase the risk of skin cancer, and that is on the rise, and we have to be so careful with that. But so it's one of balance, just getting a little bit of sunlight exposure without plastering ourselves on sun cream. And that's the same with children. And if you look at the cancer charities, particularly in Australia, the Slip Slap Slop campaign has now said a little bit of sun exposure before you then put on the sun cream.
Great, thank you. And then Beth has also asked, if people are on medication that can affect bone density, would you suggest them being on calcium and vitamin D supplements? Would they need a higher dose, e.g. long-term steroids or long-term PPIs?
I would certainly say if they are on bone medication that we know to affect bones, such as corticosteroids, yes, taking a calcium and vitamin D supplement, certainly a vitamin D supplement. If they're not able to achieve their calcium supply in the diet, then yes, consider a calcium supplement too. That's a very important point, most definitely.
Thank you. And then I think just a comment from Vicky, who says, my regional commissioning group are de-prescribing calcium and vitamin D supplements, even for those taken by phosphonates, as people can buy these supplements. It's a cost-saving measure, but doesn't feel right to me.
I would agree with that. I think we have to encourage our population. So just say that again. I'm sorry, Verity. They're not prescribing these calcium and vitamin Ds. Is that what?
Yeah. So she says they're de-prescribing calcium and vitamin Ds as people can buy these supplements.
Well, they can buy these supplements, but absolutely, people are struggling to even feed themselves. So, I would say any resistance that we can, and any way that we can raise to stop that happening and to make sure that we can still prescribe them. Certainly for vitamin D, I think if people can get it in their diet, which you can for calcium, then that's certainly something to think about. But for vitamin D, we have so many people who are vitamin D deficient, and it's a no-no for health. Your pancreatic beta cells are vitamin D dependent. So that means if you are vitamin D deficient, you have an potential increased risk of diabetes. We know that it's helpful in preventing acute respiratory tract infections. We know that vitamin D is linked to mental health. There are so many health outcomes where vitamin D has a link. And even though the randomized controlled trials might not have shown that overall benefit, RCTs are very important, but it doesn't necessarily mean that if the RCT doesn't show a benefit, that there's no need for that nutrient, because it's all about avoiding deficiency. And if people don't take a vitamin D supplement during the winter, they are at risk of deficiency.
Brilliant, thank you. That's all the questions from the chat at the moment.
Lovely. Okay, so I'm on. Madam Chair, I've got 11 minutes, so I'm now going to just rustle through. Just obviously, I've spent most time talking about calcium and vitamin D because they are the most important, and those were wonderful questions. Thank you so much.
I think there is one hand up. Have we got time for one more question? Is that okay?
Oh, absolutely.
I think is it Justine?
It is, yes. Thank you very much. So I have a question around ethnicity and vitamin D deficiency. I don't know if any work has been done on that. Also, you did mention how the numbers are worse. The figures are worse for people in low and middle income countries. And we know quite a few of those countries are in areas in the tropical region. So I'm from Africa. There's lots of sun. So it's sort of shocking that there are more people who are vitamin deficient there than here. So would you kindly speak more into that, please?
Absolutely. And I'm sorry, I didn't catch your name again.
Justine.
Oh, Justine. Justine,
Yeah.
thank you so much for your question. Absolutely. So we know that a darker the skin, you make vitamin D in exactly the same way, but your skin needs more time exposed to the sun. We, as I've said, we're now looking, so vitamin D deficiency is an issue, has greater risk of South Asians, Black Afro-Caribbeans. We've done a lot of work. If you just type in my name, vitamin D and ethnicity, it will come up with all the publications that we've done on the UK Biobank. We've done meta-analyses. So what it means is that individuals need to be careful that they take their supplement during the winter, and they allow their skin to have longer in the sun, of course being careful not in any way to allowing the skin to burn. The very important point that you make about the WHO and low to middle income countries, a lot of that is in relation to pollution, and particularly to individuals who dress for cultural style. So it would be more related to that where there is a lot of pollution or a lot of cloud cover, even though it's a sunny country, the UV rays may not be getting through that pollution, and they're where the individuals are covered up because of cultural style. That would be the main reason. Thank you. Thank you for your question. So just now to just say a few things about acidity and fruits and vegetables. So we've done a lot of work on this when I was in Aberdeen, and then when I first moved to Surrey, we did a lot of work, and I've just put up a couple of the publications there. What we show, and others do as well, is that fruits and vegetables, if you have a high component of fruits and vegetables in the diet, which is of course is something that we want from a cardiovascular point of view and many other health outcomes, fruits and vegetables. For many years, I did a lot of work on fruits and vegetables and osteoporosis. And I remember going to a few talks, and they, particularly one in the Middle East, and they said, oh, you're the fruit and veg girl. And I thought, well, if there's a nutrient I don't mind being associated with, it's fruits and vegetables, because we really don't eat enough. And it is, we need to eat it in abundance. We did many, many years ago. And of course, we've now over time, as we've become modernized, we don't eat anywhere near as much fruits and vegetables. But what we've shown is that if your diet is very acidic, so this is called NEAP, net endogenous acid production. So people here who have the highest NEAP, that means they have low potassium intakes and high protein intakes, but the offending bit is the low potassium. You will see that they are losing more bone. This is a marker of bone resorption. So you can see it's a very clear graph that they are losing more bone. If we then look at that in its entirety, and as I said, and I'm going to just skip through these in the interest of time, but what I would say is similar to that which I said about calcium. Our blood calcium levels are homeostatically controlled. So you cannot tell somebody's bodily stores of calcium through taking a blood sample. All it will tell you is whether they're hypo or calcemic, or whether they've got normal calcium levels in their blood. The same is with blood pH. The body will do anything to maintain its blood pH levels. And one of the mechanisms that it will do to make sure that if our blood pH drops, that it will use the alkali salts from bone to bring pH levels back up. And this work goes back many, many years, and you'll have all these slides so you can see the references for yourself. These were all the early studies that were done. This was the work that was done by Professor Arnett, in which he showed if you put bone cells into an acid environment, they will increase in their activity. They will become hyperactive. And this Professor Linda Frassetto, who is now retired, but she was the professor of medicine at the University of California in San Francisco, has done so much of the work. And what she has showed is that as we get older, our plasma bicarbonate concentrations go down, our blood hydrogen concentrations go up, so we become more acidic. If you look at the DASH study, so that was dietary approaches to stopping hypertension, they significantly reduced urinary calcium excretion, and they also reduced bone resorption. And this was probably the best study to show, I think, of all the studies that have been done, that you can, by changing diet and increasing fruits and vegetables, not only can you reduce hypertension, which is of course what DASH was all about, but you can also improve bone, certainly calcium balance and the amount of bone that is resorbed. These are some trials that have been done. What we've now we've just redone a new we've updated this meta-analysis, but we published this a couple of years ago, because of course you can buy alkali supplements. I wouldn't recommend them. I would say I don't think I think the jury is still out with regard to not taking potassium bicarbonate or potassium citrate as a supplement, because I think we don't have the long-term data. But if you look at the trials that have been done, they are very impressive in reducing the amount of bone resorption that you see. This was the trial that, so Dr. Helen Lambert, who's at Surrey, was first.
Rhian, sorry, could I interrupt you at this moment? Susan has managed to join again.
Okay.
I wonder if we just go back to her
yeah, I can do that.
for a moment, just so she doesn't have to stay for the whole AGM.
Yeah, that's absolutely fine.
Is that right? Thanks.
That's absolutely fine.
Well, now look, I'm so sorry, with no warning, my computer suddenly flashed up and said restarting,
was it?
Restarting.
Oh no.
So I'm so
No
sorry.
worries at all.
So it was like something out of Star Wars. So now please, I'd almost finished.
Yeah, no problem, Susan, go ahead.
Shall I just share just a couple of, obviously it's shut everything down, so let me just pull up the slides once more. Now, obviously, and I most certainly don't want to take this important time for your AGM, but if I just pull up, so what I will do, where I'd got to was just talking about fruits and vegetables. Let me just share my screen again, so that I can just show you. There they are. I'm hoping that you can see that. Let me put it in slideshow format. Can you see that, Verity, Rhian? Is that there?
Yeah.
So, yeah, lovely. So we were just talking, weren't we, about the importance of the DASH diet. We were talking about the meta-analysis that we've done. And what I was just going on to say was, these are the two very large meta-analyses that we've done. This last one was over 40 years. And this gentleman, Professor Joe Millward, who's our emeritus at Surrey, who's still at the grand age of 84, still the main WHO, FAO, UN consultant on protein. He's the most amazing man. He's guided us to do this work. And the bottom line is that protein is really important to bone. So I think in advising your patients, that healthy balanced diet with plenty of fruits and vegetables, but that has plenty of good quality protein, is so important across the board. I think all this work that we've done, certainly a lot of work on acid-base balance. So all that means is what we're trying to achieve in the diet is a lot more potassium than what we currently do. if you have a high potassium intake and a moderate amount of protein, you will have a much better acid-base homeostasis. And you can see here that acid-base homeostasis is now being deemed to be really important for diabetes risk and many other health outcomes. So, and I'm certain with time it will become more important. And then I think the other thing to just say is that vitamin K has a role in bone. I think this was the meta-analysis that we ran. We've redone this meta-analysis. It's not as exciting, I think, for vitamin K as it was. Many of the trials have not shown a benefit, but I think it's certainly mechanistically, vitamin K has a role in bone. But I think if you look at the data currently, probably getting your vitamin K from your diet will be enough. And I don't think we have enough data to strongly say that people should take a vitamin K supplement, and they certainly shouldn't if they are warfarin users. I think the only other thing to update you on would be there's been some very exciting prune work. So dried fruits, particularly prunes, through all these sort of additional antioxidants in those prunes have shown to be really quite beneficial for bone. I think we need more trials, but if you look at the most recent trial in the American Journal of Clinical Nutrition, that was very exciting in terms of helping to arrest bone loss. So really, vitamin K, calcium, protein and potassium, those are your key nutrients. And I hope that has given you a nice summary of the key aspects. And I will make sure, Verity, that you get the final copy of the slides. And, I hope that that's been useful.
Thank you so much, Susan, and thank you for coming back after the technical difficulties. We really appreciate that. I saw lots of comments in the chat to say that everybody's had a really fantastic session and found it really informative. So thank you so much.
Oh, you're very welcome. Well, thank you very much. And, really good luck in everything that you do. And, please, if I can be of any help, then please don't hesitate to let me know. All right, I'll leave you now.
Thank you so much.
Thank you so much, Susan.
Bye-bye. Bye-bye. Bye-bye.